Yes, fantastic evening, my dear friends. Welcome to NEET PG recall session Pharmacology from DAMS Alpha. Very fantastic evening, Dr. Nikki Krish Agarwal. All good, fantastic. Let's start. We collected some questions from the students. I am going to recall all the questions from pharmacology paper. To start, the first question: a 35-year-old man diagnosed with Pheochromocytoma after presenting with episodic headache, palpitation, and hypertension. Imaging confirms that arterial mass. So definitely he has Pheochromocytoma and is scheduled for surgical resection. Which of following drug is best used pre-operatively to control BP in such case? What answer you made in the exam paper? The right answer for the question go for phenoxybenzone. It is the non-selective, irreversible alpha blocker. It is a wonderful drug for controlling blood pressure in patients with Pheochromocytoma. Look at the other option, claudin. Claudin is centrally acting alpha antagonist, useful for hypertension. Okay. And intra. Okay. Pre-operative as well as intra-operative. Okay. So among this list of options, even though pre or intra-operative, the best is go for phenoxybenzone. During operation for immediate control of hypertensive crisis, we may go for phentolamine. Also, we can go for sodium nitroprusside. So, usually for controlling BP in a Pheochromocytoma patient, use prophylactically oral phenoxybenzone. During operation mean to control BP urgently, we can go for intravenous phenytolamine, a short-acting, reversible, non-selective alpha blocker. So short-acting drug, reversible drug, non-selective alpha blocker. Or we go for nitroprusside. So among this answer, the best answer go for option A. Okay. Aspirin antiplatelet, there is no role in this case. And esmolol, a ultra short-acting beta blocker, useful for emergency. But pre-operatively it can be used because it is only intravenously, only for emergency, not for chronic purpose. One more thing, for treatment of hypertension in these cases, always first go for alpha blocker. Don't never go for beta blocker as a first choice. So it can be choice. So right answer go for phenoxybenzone. So normally what Harrison book says, for controlling blood pressure in this case of catecholamine secretory tumor, so called Pheochromocytoma, the best answer go for phenoxybenzone. It's a fantastic choice. During operation to control the BP, we can try IV phentolamine or IV nitroprusside. Whereas remember, never go beta blocker as a first line choice because that to never go propranolol because propranolol is a non-selective beta blocker. Use this, they're going to block all the beta 1 and beta 2. So the released adrenaline acting only alpha. That is unopposed alpha action causes severe hypertensive crisis. So the best answer for the question go for phenoxybenzone. That is first question. Coming to the second question, ready? A 55-year-old man is undergoing a general anesthesia for abdominal surgery. Shortly after administration of a non-depolarizing neuromuscular blocker, he developed a bronchospasm, hypotension, flushing. Which of following SMR is most likely responsible for this untoward reaction? See, all the bronchospasm, hypotension, and also flushing are due to histamine releasing property. Histamine releasing property. So asking which is the SMR having high amount of histamine releasing property? Answer Tricorium. Tricorium, one of the non-diversal having high risk causing bronchospasm, flushing, hypotension. Whereas cis altracorium does not has histamine releasing property. Pancolium also not that much having, and this has one important property of anti-vagal property because tachycardia. And Vicronium has has minimal cardiovascular problem and very minimal risk of histamine related problem. So best chance go for Artricorium. Good. Something silent, good, fantastic. Now we move on to third question. A 25-year-old male undergoing surgery and general anesthesia with sevoflurane and succinylcholine develop rapidly increasing body temperature and muscle rigidity, tachycardia, and metabolic acidosis. Patient undergoing general anesthetic procedure using sevoflurane and succinylcholine and developed increased body temperature, muscle rigidity, tachycardia. All the symptoms suggestive of malignant hyperthermia. A general anesthetic causing hyperthermia, one can be halothane, or else we can go for succinylcholine. Succinylcholine, one of the SMR, it is also has a risk of causing hyperthermia. The question asked here, which of following is the treatment of choice for this case? So, patient developed many hyperthermia. For treating this case, what is best? The best answer go for dandrolene. Dandrolene, one of the directly acting SMR. When I say directly, I mean acting on Raynaudine receptor. By blocking the Raynaudine receptor, inhibiting release of calcium, thereby having muscle acid property useful for treatment of hyperthermia. Remember, it's also very fantastic drug of choice for malignant neuroleptic syndrome. So drug of choice for hyperthermia, also malignant neuroleptic syndrome. Okay. Diazepam paracetamol has not that much role in this case. So it is clear in case of many hyperthermia. For this case, the best drug of choice go for dandrolene. Okay. Right. Next question. A 36-year-old woman with the history of severe eosinophilic asthma continues to have experience of frequent exacerbation of asthmatic attack and even being on high dose of inhaled corticosteroids and long-acting beta agonists. Even though patient on ICS plus LABA therapy still complaining of frequent episodes of bronchospasm. Her eosinophil count was significantly elevated. The pulmonologist decided to start benralizumab and iron therapy. What is the mechanism or what is the target of benralizumab? Can you please answer, my dear friends, who are attending live session of YouTube channel? Can you please answer what the answer for this question you made in your examination? Benralizumab, a monoclonal antibody useful for asthma targeting against IL-5. So interleukin-5 receptor IL-5 receptor blocker IL-5 receptor blocker, that's important. Okay, so answer option C. Whereas TNF-alpha blockers are mainly useful for rheumatoid arthritis like infliximab, adalimumab, golimumab, certolizumab. All are drug useful for mainly rheumatoid arthritis as well as for inflammatory bowel disorder. IL-4 blocker, we have one thing called dupilumab. It's the IL-4 blocker useful for bronchial asthma, as well as useful for treatment of atopic dermatitis, useful for atopic dermatitis. Then IL-13 blocker, we have lebrikizumab and tralokinumab. These are MEB for asthma. For this question, you should know, actually asking good question. Bendralism, IL-5 blocker. Actually, when you talk about antibodies for asthma, we have an antibody targeting against IgE called omalizumab. Omalizumab antibody targeting against IgE, whereas the IL-4 blocker we call depemokimab. The depemokimab acting against IL-4 and 13, useful for bronchial asthma as well as useful for treatment of atopic dermatitis. Whereas IL-5 blocker we having mepolizumab, reslizumab, and bendralisumab. Actually, they are given cakewalk question, easy question. Suppose if they want to be tough question, they should ask these two are direct IL-5 blocker, whereas bendralisumab is IL-5 receptor blocker. Thereby, the IL-5 not mean the receptor not able to act on IL-5 receptor. That's the point. Okay. And one more thing, the mepolizumab, in addition to asthma, useful for treatment of Chaptras syndrome. Chaptras syndrome. This is so important. Chaptras syndrome, adverse effect of so-called montelukast. Montelukast on chronic therapy causing headache, eosinophila, and vasculitis. For the Chaptras syndrome, we can try steroid. Also, we can try mepolizumab. Okay. And then next question. What are the other important latest antibody for asthma? We have something called thymic stromal lymphopoietin blocker, TSLP. Thymic stromal lymphopoietin blocker, so-called tezepelumab, a latest MEB useful for treatment of bronchial asthma. And IL-13 blockers we have tralokinumab and lebrikizumab, along the most important monoclonal antibody useful for treatment of bronchial asthma. They ask me this question: bendralisumab targeting against IL-5. That's all. Now coming to next question. Ready? A 30-year-old woman with the history of bronchial asthma is currently using salbutamol and ipratropium mid-rate dose inhaler as needed. She reports frequent nocturnal night symptom, including wheezing and breathlessness that wake her up several times in a week. What is the most appropriate next step? Look here, patient was already on salbutamol. Salbutamol, one of the short-acting beta-2 agonists. And also on ipratropium. Ipratropium is one of the short-acting muscarinic antagonists. Both are bronchodilator. So even though patient on bronchodilator still complaining of nocturnal symptom, frequent night breathlessness, frequently going to waking up. So for this case, what instruction? The best answer for the question go for LAVA with ICS. So today guideline says the best treatment for this case will be go for inhalation corticosteroid plus long-acting beta-2 agonist. That's the best answer for the question. Okay. Called mental cost, yes, we can add. It's later after controlling the symptom. Later on, we can try this. So it can be added later on, not acutely. Increasing the frequency of current medication. See, when you increase the current medication, unnecessarily going to cause adverse effect. Here, these two are only bronchodilator. They don't control the underlying bronchial inflammatory pathology. They don't control the core problem in asthma. So, the best is go for LAVA with ICS. And add oral shots. Oral shot can be useful in acute cases, in severe cases, not for chronic purpose. So, today the guideline says for chronic purpose, the best is go for LAVA with inhalable corticosteroid. So, answer option B. Okay. So, anybody want to say any option? Any? Come on, Nikki, please, Sugarwood, Salem. Anybody who is following, can you please say your inputs? Okay. Now, we move on to question number 6. A 6-year-old boy is brought to emergency department with a journalist clonic seizure. has fever of 102 degrees Fahrenheit for the past few hours. And this is it's a first seizure episode for him. Okay. Now, he is not any other medication. He has no past initial seizure or no neurological problem. What is the most appropriate immediate treatment for this child? Anybody want to answer? See here. Okay. His case of fever with epilepsy called febrile convulsion. No question starts. For a febrile convulsion, the best drug choice always go for rectal diazepam. Rectal diazepam is the best. So, a child with fever and febrile seizure, for the best option go for rectal diazepam. Quinine anti-epileptic for generalized tonic-clonic seizure, not for fever-induced seizure. So it's not answer. It's not a question choice for this case. Valproate on a broad-spectrum anti-epileptic drug, but not for acute episodes of febrile seizure. Okay. If those suspect a T type of CCB, it's primarily useful for treatment of absent seizure, not for this seizure. Okay. So answers go for diazepam. Then what's number 7? The super question. A schizophrenic patient on haloperidol was responding well for the last 2 years. Now presenting with orofacial dyskinesia, choreoform movements, and possibly dystonia. What is the probable diagnosis and treatment? See, patient is on haloperidol is one of the D2 blocking antipsychotic. We call them typical antipsychotic. Is for the past 2 years. Present with the orofacial dyskinesia and choreoforms that we developed EPS, one type of extra symptom. And orofacial and choreoform movements are typically tardive dyskinesia. Tardive dyskinesia. The tardive means late onset. Patient was taking for 2 years. So on chronic therapy, late onset problem or tardive dyskinesia. For this case, the best drug choice go for valbenazine. So answer option will be tardive dyskinesia treatment valbenazine. Whereas look at the other option. Acute dystonia, we don't go for opioid. Ropinirole, one of the D2 agonists useful for treatment of Parkinson, also useful for treatment of restless leg syndrome. For acute dystonia, we can try centrally acting anticholinergic like benzoxazole, or we can try promethazine. So it's not answered. Akathisia, we can use propranolol, but his symptoms not size of akathisia. Akathisia means restlessness, urge to walk. He is not able to sit in one place. He urge to walk, restlessness. So it's not this case. Oral tremor. It's not his oral tremor. Actually, amenturing an antiviral drug useful for treatment of levodopa-induced dyskinesia. It can be useful for treatment of levodopa-induced dyskinesia. Okay. Now, the right answer go for tardive dyskinesia. Okay. So it is a typical orofacial, linguo-masticatory movements. A typical presentation of tardive dyskinesia, one type of EPS. For this case, the FDA approved drugs go for valbenazine. Valbenazine, okay. It's a VMAT, vesicular monoamine transporter, VMAT blocker. Of course, just a look on other type of EPS. We want to think of acute muscle dystonia. For this, we can go for treatment with the centrally acting anticholinergic like benzoxazole, or we can go for promethazine. Promethazine is a first generation antihistamine having high amount of central anticholinergic property. Okay, and then akathisia. See here, akathisia is the most common type of EPS, but the presentation is restlessness. He is not able to sit in one place. He is wandering here and there. For this case, best drug choice go for propranolol. Originally, we can try benzodiazepine like clonazepam. Whereas one more thing, a rare type is called Malignant syndrome. For this case, drug choice dandrolin. Dandrolin is directly acting as the marketing on Raynaud receptor, blocking the release of calcium. It's the best drug choice for this case. Usually, you can try bromocriptine. Bromocriptine, a D2 agonist can be supportively given, but best choice is dandrolin. Okay. So next question. Yeah, beautiful question. Cardiology. There are two interesting questions from arrhythmia chapter stuff. Okay. Question one. A 6-year-old man with a history of ischemic cardiomyopathy presents the palpitation. ECG shows narrow complex tachycardia. His hemodynamic is stable. The addition was made to start amiodarone. Question. It is what is the amiodarone primarily acting on which phase of the cardiac action potential? Anybody? See, amiodarone, we know a class 3 anti-arrhythmic. Class 3 that means potassium channel blocker. If we know this one, answer very simple. In the action potential, phase 0 indicate sodium endrain. Phase 2 indicate calcium endrain and minimal efflux of potassium. And phase 3 is the main phase where potassium efflux happening, causing repolarization. So, okay, yes, doctor, yes, vandalism just acting by no history. Good. So, in the very simple, vandalism acting against what? Simple, straight one-liner. Anyway, the answer is going for IL-5 blocker. Okay, thank you. XY 456, thank you. Right, now, our is a class 3 drug, potassium blocker, that means going to act on phase 3 of the action potential. Okay, so phase 3 called E plus of potassium, all the class 3 drug acting on phase 3. Primarily a potassium blocker, it also has sodium blocking property, calcium blocking property, also in beta blocking property. But the primary action is potassium blocker. So answer phase 3. Phase 3. Okay. Yeah, good. No. A 28-year-old woman presenting with the recurrent episodes of sudden onset of palpitation, dizziness, and mild chest discomfort. He is during one such episode confirm paroxysmal supraventricular tachycardia, PSVT. Which of is the drug of choice for prophylaxis of PSVT? Okay. For this case, drug of choice for acute episode treatment. Treatment of choice will go for IV adenosine. Whereas the prophylaxis. Whenever you are treating PSVT cases, remember one time they develop the SVT, they are going for recurrence of SVT. So to prevent the recurrence of SVT, you put them on oral CCD like Verapamil. So in this case, go for Verapamil. So IV adenosine is the drug of choice for acute SVT cases. Here asking prophylaxis, so go for oral. And IV Asthma only for emergency, not for prophylaxis. So rule out. Fentanyl, a class 1B drug, usually it comes under anti-epileptic. In cardiology, it comes under class 1B drug, has a role as anti-arrhythmic for treatment of something called ventricular arrhythmias. For example, useful for treatment of digoxin-induced VT, like this. So all the class 1B drugs are mainly useful for treatment of ventricular arrhythmia, not for supraventricular. So the state question, answer option D. Now look at. Normally for case SVT, in case we go for either IV adenosine or IV both tests. But theoretically, the best drug choice go for IV adenosine, rapid IV bolus injection. Or else we can try Verapamil also. Whereas once you then reversal, there is a chances of recurrence of SVT. So to prevent the recurrence of SVT, put them on prophylactically to prevent recurrence of PSVT, put them on either oral beta blocker or oral Verapamil or oral amiram. They ask oral graphite. So the answer for the question oral graphite. Okay. Then next question. Okay. A 30-year-old woman has recently undergone a cesarean section and has multiple risk factors for venous thromboembolism, including obesity, prolonged immobility. The obstetric team decided to start postpartum thromboprophylaxis. Which of the following is the drug of choice for preventing venous thromboembolism in this immediate postpartum period? Can you please answer? What answer you made in your exam? Can you please answer? See, actually, patient undergo cesarean section. Following LSAS, they want to start they want to start prophylactic therapy for venous thrombosis. Okay. Now, options are LMWH, aspirin, clopidogrel, valproate. Aspirin, we know, antiplatelet. It is not for DVD. It is also antiplatelet. It is mainly for arterial pathology, not for venous pathology. So, these two things ruled out. The answer will be either LMWH or valproate. See, this is an injectable drug given subcutaneously, rapid in onset. So they want immediate thromboprophylaxis. So here I want rapid action and also safer drug, no need to monitor is required for LMWH. Whereas warfarin also in postpartum period often safe. But thing is, warfarin needs 3 to 4 days for the full benefit occur because acting by inhibiting vitamin K dependent on the factor. So to inhibit all the 2719, it is around 70 dose. So it is delay in the onset of action, during onset, and it needs wondering. So because of all these reasons, my choice I go for option A, LMWH. Okay. Now, so one for it takes several days to become good benefits. Now, question number 11. A 60-year-old man with chronic kidney disease, CKD patient, having paleness, progressive dyspnea, signs of symptoms of heart failure, lab result shows normocytic, normochromic anemia. What is the most appropriate manner for this case? Can you please answer? What do you may answer? CKD with anemia mean always best to go for erythropoietin. CKD mean all go for erythropoietin. So best look for option. The best is among option. We go for darbepoetin alpha. It's a longer acting erythropoietin preparation. That's the best answer. Whereas the iron preparation is useful for treatment of iron deficiency anemia, not for this case. And filgrastim, one of the colony stimulating factor useful for treatment of neutropenia, not for anemia. It is useful mainly for treatment of anti-cancer drug-induced neutropenia. So best answer go for option A, darbepoetin. Okay. Question number 2. Anybody? Can you want to say anything? Please put in chat box. Clothalidol prevents real stones formation by what mechanism? Options are decreased oxalate excretion, decreased citrate excretion, decreased calcium excretion, increased calcium excretion. Look at clothalidol, one of the thiazide group of diluting. Thiazide has the property of causing calcium reabsorption. That means that prevents calciuria. Whenever there is a calciuria, risk of stone formation. So thiazide, by inhibiting calcium excretion, controls stone formation. That means they decreases calcium excretion. Whereas remember, loop dilating. Sir, this was not in the question. Okay. So controversy. Okay, please. So somebody told sir something stone and diuretic something. Okay, contrast means this question. Okay, Herschel, this Herschel. I leave the question. Anyway, just remember, thyroid causing calcium reabsorption, diuretic causing calciuria. They cause adverse effect of stone formation. Okay, so I leave. Anyway, somebody posted in WhatsApp number. There's a question on this. Anyway, very clear. Okay, so if particular question, thyroid prevents to mainly by decreasing calcium excretion. Okay. Okay, actually, Saram, I don't want to make controversy. What they say, they may have very minimal effect on certain excretion. But ultimate action of thiazide mainly by decreasing calcium excretion. Suppose if this option given me, this is best. If this option not given, then we can go for this man. Okay. So both are okay. So look here. Suppose what they say, if this option is there, it is the best answer. If the option not given, next best answer go for this. Okay, because in government they mentioned. See, question was hypertension on the other side, and then develop these stones. What is the mechanism of stone due to okay. So they causing stones. So really controversy. So thyroid is useful for treating stones. Anyway, doctor, we check it. Okay. Question number 13. A 40-year-old man with a history of gastroesophageal reflux disease presenting the symptoms of and persisting symptom respect of taking proton pump blocker. He reports regurgitation and bloating sensation. The physician concerned switching to a drug that going to tighten the lower is a sphincter and going to promote gastric emptying. They want some prokinetic agent to relieve the symptoms of GE or D. So asking what is the best prokinetic? Options are omeprazole, omeprazole, metoclopramide, sodium alginate. The best answer metoclopramide. Actually, it's a T2 blocker having additionally 5-HT4 agonism property plus 5-HT3 antagonism property. Okay. That's what I'm confusing. How can someone do stone do like that? That was confusing. I don't know why the question was made. Okay, there's a problem. Clients are useful for treating stones. Anyway, they're very big. Okay. Metoclopramide, a prokinetic agent, so D2 blocker having additionally 5-HT4 agonism plus 5-3 antagonism property. Whereas omeprazole is there, potassium commutative acid pump blocker. Acid pump blocker useful for treatment of gastritis. Omeprazole, H plus, K plus, ADS, proton pump inhibitor. Sodium alginate, one type of antacid. In the antacid, they forms on layer. The layer preventing regurgitation. Type of antacid. So answer straight question. Answer C. Metoclopramide. Okay. Then question 14. You have 50-year-old man with type 2 diabetes on metformin and diabetes patient with hypertension or worsening of dyspnea and fatigue. Echo source LB ejection fraction 35%. Which is the anti-diabetic drug is more appropriate for the case? They straight want to ask, name the anti-diabetic drug got approval for treatment of congestive heart failure. Answer MPA gliflozin. Look here. Pheochromocytoma, a PPAR gamma agonist, it causing fluid retention. It itself causing adverse effect of heart failure, causing heart failure. Okay. Then, among the gluten, gluten causing adverse effect of heart failure. And glutamate has no such risk. So here, which is useful for treatment, means go for MPA gliflozin. Okay. Jodi, the answer was given. Okay, the question was given, but options are not clear, but question stem also not clear. Okay, anyway, we will verify that question. That's the role verify. Right. Now, this question, I think, very fantastic question. Anti-diabetic useful in the treatment of heart failure. Go for SGLT2 blocker like dapagliflozin, empagliflozin, and sotagliflozin. Whereas you should know which are the anti-diabetic or causing heart failure. This is important. And subsequently causing heart failure. Okay. Anyway, the question was very easy question. Anti-diabetic useful for treating heart failure. DAPA, EMPA, and sotagliflozin. They given EMPA, gliflozin. Easy question. Okay. No. Can you please answer, man? This question came or not? Somebody given in my WhatsApp number, sir, diabetes, and I will put something question. I don't know whether it came or not. Please look at the question. A patient with the history of diabetes, RBS, sugar, 500 milligram per liter, sodium 126 milligram, potassium 4 milligram. Which of following step is not useful in this management? Okay. I think it's a case of diabetic ketoacidosis because they are in high blood sugar with look at this. Kim. Okay. So in this case, insulin is a drug choice, but when you do insulin, chances of hypocalcemia is there. So minor production, and whenever it decay, lot of fluid loss. So this is important. So let's go for option D. But this is indicated only for severe symptomatic hypothermia with a seizure, not routinely. So the best is go for R720. Yeah, okay. R720. Okay. Uncontrolled diabetes, good. Okay. Yeah. I guess it's above 700. Okay, no problem. Divya, I put 720, above 700. So for this case, best answer go for option D. Okay. Next question. Which is the primary mechanism by which pegloticase reduces uric acid? See, your pegloticase, a recombinant uricase analog. Useful for treatment of hyperuricemia. The uricase enzyme causing what? They cause metabolism of uric acid, converting uric acid into allantoin, a water-soluble allantoin. Conversion is by what process? That's the question. It is by oxidation. Question. Ras buricase. One more drug called ras buricase. One more drug called pegloticase. Both of them are recombinant uricase analog. Going to cause oxidation uric acid into allantoin. That way, it is easily water soluble and get excretable. Okay. Whereas look at option A. Xanthine oxidase enzyme blockers of merely allopenol and fluoxetine and drug inhibiting URAT transporter, that is propenicillin. Propenicillin inhibiting uric acid absorption, causing uricose uric property. Okay. So anyway, the answer recombinant form of uricase analogs was so-called ras uricase and pegloticase going to cause oxidation of uric acid into allantoin. Okay. Next. This is another tricky question. One controversial question. Look at a 32-year-old woman with the migraine was started on sumatriptan. She has no comorbidity, but has a positive family history of coronary artery disease. After the first dose of sumatriptan, she developed chest tightness. She is now planned for migraine prophylaxis, which is the most appropriate drug for prophylaxis for this lady patient. Can you please answer? Patient is a known case of migraine, was started on sumatriptan. So, sumatriptan. Triptans are 5-HT1B agonist. They cause vasoconstriction that by immediately controlling migraine. But after starting that, she developed a chest tightness that is vasoconstriction causing vasospasm causing some chest tightness. Okay, tightness. Now here, there's a family history of coronary artery disease. The question was, look here, which is the most appropriate drug for prophylaxis? Look at this. So, triptan. So, triptan called 5-HT1B agonist. Triptan is useful only for acute. Ergotamine, a vasoconstrictor, useful only for acute. So, these two are useful only for acute case, not for prophylaxis. That's all. My doubt is option A or B. Come on, Nanda Shaurov, say one controversy. What I want to say is, look here. Patient was given somatroptan, developed chest tightness. It's due to vasospasm of the coronary artery. Which also has the family history of coronary artery disease. So in this case, what may be the best answer? Nothing. Propranolol, a very fantastic drug for migraine prevention. I do agree, but it's a non-selective blocker, beta 1 and beta 2 blocker. If we give this, they block in beta 1 and beta 2. If we block beta 2 causing vasoconstriction. When you block that, they're going to cause unopposed alpha cause vasoconstriction. So propranolol may cause vasoconstriction. Actually, wonderful drug, first line drug for migraine prophylaxis. But she said already just tightness. In this case, if you put this problem aggravated, so I think we are good for topiramidal. Topiramidal, anti-epileptic, has no cardiac abnormality at all. It may cause adverse effect of kidney stones, may cause renal stones, sometimes causing weight loss, rarely causing angle closure glaucoma. They don't cause any cardiac adverse effect. Okay. So I think answer will be topiramidal. But only one beta blockers are wonderful drug for CAD. But this patient, even of small triptan developing chest discomfort, mean patient also in family CAD mean why want take risk? It's the best no contact product, so better go for this. Okay. Anyway, this is my choice. This can be second choice only. So ultimately, best chance to go for topiramidal. Okay. Next question number 18. A 36-year-old man present with fever, weight loss, chronic cough, diagnosed pulmonary fibrosis, and HIV test positive. So TB with HIV case. Okay. Now, is not on any anti-inflammatory. Okay. So now the question, patient having TB and HIV, in this case, how to approach? Remember, whenever you have a case of TB and HIV, always first give treatment for TB. Never start HIV first, because when you start HIV first, they are going to cause immune reconstitution inflammatory syndrome. So the concept is, whenever TB and HIV is there, first give treatment for TB, and then based on the C4 count, start treatment for HIV. If the C4 count less than 50 mean, within 2 weeks you can start treatment for go for LT. More than 50 mean, wait for 8 weeks. So here answer, start first ATD and then wait for 2 weeks and then start the anti-retroviral therapy. Right? So this answer, go for C. So what the guidelines says, look at the guidelines says, look at the whenever you have HIV TB with HIV patient, the guidelines says always start ATT first. Okay. When we have to start treatment for HIV, it's depending upon the C4 count. What they say, the C4 count less than 50 mean, give 2 weeks gap. So first treat TB, give 2 week gap, and then start giving ART. C4 count more than 50 mean, wait for 8 weeks. In case the meningitis, irrespective of C4 count, go for 8 weeks gap. So in your question, best answer, first start treating TB, give 2-week gap, and then start treatment for HIV. Okay. Next. A 40-year-old man with a newly diagnosed HIV infection and having low grade fever, what we call weight loss. And sputum gene expert reviews make TB with rifampicin resistant case. So, HIV patient with rifampicin resistant case. For this case, what is the most appropriate management? Look here. Start BPAL regimen. Start HEZ regimen. Look at this. Here is a case of MDR-TB. For this case, best is go for Britamanic, bedaquiline, lidisolid, moxifloxacin regimen for 6 months and check for immune reconstitution inflammatory syndrome. It is the best answer. Whereas the levofloxacin is second-line drug. It is not complete treatment for MDR-TB, and this one is also a second-line drug for TB. It is not complete treatment for MDR-TB. Ketamine is aminoglycoside injection-based. So nowadays become outmoded. The best treatment for MDR-TB go for bedaquiline, Britamanic, lidisolid, moxifloxacin, and follow for 6 months, and also look for iris product. So answer option A. Come next question. I think super question. Who is going to answer? A 90-year-old college student having emergency problem, attend emergency with a high fever, headache, knuckle rigidity for the past 1 day, and exercises Dixon sign are positive. That means something like meningitis, and CSF shows what's increased opening pressure, turbid appearance, high protein, low glucose. Gram stain shows gram-negative diplococci. That means, can you please answer? What is the proper diagnosis? Case of meningococcal meningitis. Okay. Which one drug of choice for chemoprophylaxis for the conduct of this patient? So, for this case, the best prophylactic drug may go for rifampicin. That's the best answer. It is a choice. Almost is no role. The other drug can be useful for this case will be either ciprofloxacin or ceftriaxone. But the best is always go for rifampicin. Okay. Chlorphenical is useful only for treatment, not for prophylaxis. So I go for answer option by A. Right? Now, see, in antimicrobial, they mainly focus on TB, HIV. That's all. That's all. Okay. The HIV pregnant female, doxy also there is option. Okay, I think in Cipro they put doxy, right? Right, doctor? In Cipro they put doxy. Okay, actually, what they say for this case, prophylactic therapy, drug of choice for patient, alternate can be either ciprofloxacin or ceftriaxone. Okay, right. So I think it's a cipro. They may put doxy. I think so. Yes, good, Mr. Shrajavan. Thank you for your compliments. Okay, now. The HIV pregnant lady presenting to hospital the third trimester, viral load was 1,200. Look here. A HIV positive pregnant female in third trimester, viral load 1,200. That means high risk pregnancy. One day. She was started immediately on anti-read therapy. She gave birth to a healthy baby of 38 weeks of gestation and normal delivery. The baby is kept on exclusive breastfeeding. What is the most appropriate prophylaxis for the newborn? Look at a HIV mother That too in third trimester at the time of delivery having viral load of 1200 copies per ml and done normal delivery. So this baby has high risk baby, highly prone to develop HIV. So to prevent the infection in the newborn baby, I want some prophylactic drug. Usually we go for nevirapine for 6 weeks normally, but in high risk patient, nevirapine alone not sufficient. We need zerodin also. So nevirapine plus zerodin are useful for high risk. Normally in high risk baby, we use zerodin with nevirapine. But the point is, how many weeks they are given zerodin plus nevirapine? One more option. 6 weeks are nice. Here, exclusive breastfeeding means there's more chance of getting infection. So better give for 12 weeks. So zerodin nevirapine 12 weeks best for this case. Yes, sir. If this option or if this line is not given, we can go for this. But exclusivity means better to give 12 weeks therapy. So zerodin nevirapine given for 12 weeks with continuous ask mother to continue breastfeeding. The answer is option D. Now, I think another important question, the question came. This question, actually, what to say, whether pharmacology or psychiatry or dermatology, we don't know. But the question here, okay, a patient on some medication complaining of oral lesion, that is purple colored lesion, has been on medication for the last 6 months. He developed a burning sensation on intake of spicy food. Which of following medication is responsible for this event? Come on, lecture. What is the picture given? Can you say this picture or some picture? I just searched in Google. What is the exact picture? I'm not getting. Anyway, this is purple color lesion in the oral cavity. This was even given. Patient some drug. Usually, they want to ask you which drug causing lichenoid eruption. So, what answer you made? Can you please answer what answer you made or you left the question? What is what you made? Here, when searching article, this problem more with lithium. This is lithium, maybe the most probable cause for this lichenoid eruptions. Next can be propranolol. Okay, oral mucosa has bluish. Okay, mucosa bluish color, mucosa bluish color. Okay, somebody told purple color. Anyway, so the question, lichen eruption, most probably due to lithium. But remember, next thing, propranolol may also cause this type of problem. Whereas ciprofloxacin is not. There is mainly tendinitis, partly damage like this. Fluconazole antifungal, they don't cause this type of problem. So best answer for this question, we can go for option A, lithium. Okay. We have done all of the important question asked in our pharmacology session. I think I completed all the questions. If any more questions there remain, can I please put to me? Actually, this post in email post our DEMS Alpha channel, Telegram channel, or to my Telegram channel, or to my WhatsApp number. So be happy. I think all the questions you may be done very well. So I'm praying from my bottom of heart. You're all going to get a very good rank. So may God bless you. All the leaders. When you see next time, you should be a very good postgraduate. Okay. So thank you all. May God bless you. I think this session was useful. Can you please answer? Okay. With this, we are finishing this session. Thank you once again. May God bless you. All very best. All very best. Thank you. Thank you.